I know this is a difficult and tricky time for especially people who are in the healthcare sector. So I really appreciate you finding time to join this webinar. I think few people are still coming on board, and I will give maybe a couple of more minutes just in case someone is rushing to join the webinar, and then I will start soon. Thank you for your patience.
Hi, Sarang. This is Siddhartha here. Good afternoon.
Hey, Siddharth, yeah, you could take over for the quick introduction and then let me know when to start.
No, I think, I don't know if everybody has joined, but the context behind this seminar is right in the headline of the first slide. We wanted there's a lot of discussion within NatHealth, and there's a lot of anecdotal evidences within the industry as we discuss with government. This is a topic that generates a lot of emotion. So it was good that Indian School of Business has done an independent study which brings independent evidences on the table. So the purpose of this seminar is to look at the facts. Dr. Sarang Deo is the executive director of Indian School of Business at Hyderabad. I've known him for many years. So it was important for us to get the industry together and just look at the evidences on the table, which hopefully can make our discussions so that we can have a more informed and a more evidence-based discussion. So that is the context of this seminar. Over to you, Dr. Sarang, and your team. Thank you.
Thank you, Siddharth. As Siddharth mentioned, this is a study that we did a few months ago, got recently published in Social Science and Medicine. And it came out of this exactly same place that Siddharth mentioned. There were a lot of emotions, a lot of heated debates and discussions on the policy of controlling prices for coronary stents when it first came out in 2007, got renewed in 2018. And we thought that we should try and look for evidence and data and analyze this in a dispassionate manner. Of course, as it happens with many research projects, it's good to have a question, but it's another thing to have the requisite data and be able to say things with some degree of confidence. So it took a while to come to this, but fortunately or unfortunately, it seems that the topic is not completely dead. There's still ongoing conversations and discussions on how to take this forward. So hopefully this is still somewhat timely. This is a joint work. Let me acknowledge my co-authors. Hanu Tyagi is a PhD student at the University of Minnesota. He led most of the analysis when he was a research associate at Indian School of Business at the Max Institute of Healthcare Management. Himasagar is a master's student at Carnegie Mellon. He was also an analyst at the Max Institute when the study got started. And Chirantan Chatterjee is now at IIM Ahmedabad, but he was a faculty member at Indian School of Business when we commenced this study. So it's a joint work between all of us. And those who joined late, I'm Associate Professor of Operations Management at Indian School of Business. This is what I plan to do. I hope it's okay with everyone. Given the format of interaction, I would like to go through all my slides, and it would be very kind of you if you could make notes and note down questions that you could ask after the presentation is done. That way it minimizes sort of back and forth, which is difficult in this kind of a format and platform. Before I begin, I wanted to start with some basic premises and approach that I have followed. First of all, I do not have any conflict of interest. This work was not funded by industry of any sort. And so to that extent, the views are those of the authors. Please note that I will show you some results on the impact of policy change later, and those should be interpreted as on average results, on average effects. We are not commenting on specific hospitals or doctors. Again, going back to Siddhartha's comment, this is an emotional topic for many of us. So I want you to take this on a fact basis. We're not making comments on specific entities. Also, I will describe the study context, and it would be best to interpret the results in that context. We can conjecture what the generalizability of the results would be to other devices and other health systems, but we don't claim such generalizability. I will talk explicitly again later when I show the results. Also, as an academic, I think here with limited evidence that we have, we are not able to, and we don't intend to pass judgment on this particular policy of price control for coronary stents was a success or a failure, whether we should do it or not. We are trying to understand what may be the drivers that make such a policy effective or ineffective. And I think people who are appropriately placed can then weigh the evidence and take this into their decision making. And I'm happy to discuss that more after the formal presentation is done. But I wanted to start with these caveats, so to speak. Okay. So this is probably not news to most of you. It's very well known that the burden for cardiovascular disease in India is large, is increasing rapidly, and it leads also to economic burden beyond just the immediate health burden. What is probably not talked about a lot is that this is not the disease of the rich. This is affecting people from lower income strata and also affecting people from rural areas as much as there is a growth in urban areas. So it's not a problem in pockets, it's a problem across the country and sizable magnitude. Now, of course, this is known, at least in the relevant circles, and this led to a few years ago a demand or a clamor for reformulating the pricing policy for some of the inputs that go into cardiovascular procedures, in particular the stents. So I have sort of put down here various news articles, also opinion pieces by different people about the need to control the prices of stents. Again, these are not my personal opinions. These are from news reports or journals and quote specific people in specific places. Of course, there was also then the NPPA who took note of this. So in 2014 or 15, they started looking at this and created a report on whether there is indeed a need to fix prices for these products. And the inputs that they got were beyond these news reports, also from FDA commissioners and different regulators across different states. So you can see, for instance, there is the Commissioner FDA in Maharashtra requesting for fixing MRPs for medical devices, including stents. I have copy pasted again a excerpt from the report on pricing of stents by NPPA, where there is a request from DPCO or recommendation from DPCO that there is significant increase in prices recently, and that there is probably extensive, huge margin structure between distributors and hospitals that need to be brought under control. Okay? So this is the background that then led to the actual change in the policy or introduction of the policy, the order that restricted or introduced the ceiling price for these products. What I'm showing here on the left-hand side is, again, a memo that describes some price calculations, or rather cost calculations, that went into the calculation of the price ceilings. Again, there are detailed calculations in this document. I'm happy to share those references, but for the sake of the presentation, I'm just saying that there was some quote-unquote due diligence done to arrive at these prices. There were two prices. So this is order 13th Feb 2017. One was on bare metal stents and the other was on drug-eluting stents. Some description of what those are. Bioresorbable vascular scaffold biodegradable stents. And these were the prices. So 7,260 for bare metal stents, and for the drug-eluting stents, 29,600. Very quickly, there was a revision or an addendum that in addition to these prices, also capped the margins in the value chain, different parts of the value chain, to about 8%. So that's sort of mentioned here. And then about a year later, these prices were revised. Again, I have air quotes here when I say revised, because they're really 7,260 to 7,400, and then 29,600 to 30,180. And the policy continued because the initial order was valid for 1 year, and it was agreed that it would be revisited. So this is the background context, and then the policy itself. There were measures put in place to monitor adherence to this policy by different players. I'm not going into that. I also do not have very good first-hand information on how that monitoring was actually implemented, and what compliance measures were put in place, but we can discuss that later. Of course, this is a huge change in the way business was being done, and immediately there were news reports about what will happen, what is happening as a result of this price control. The first reaction being that the imported stents, which are typically the high-end and the more advanced technology, would possibly find this unattractive and would leave the market, and maybe there will be more domestic players. The assumption being that domestic players have a more competitive cost structure, and they will be able to serve the market better with these lower prices. And again, there are news reports about how these medical device manufacturers are viewing the impact of this regulation. And then some sort of, this AdvaMed, supposedly a lobby group from medical devices companies, saying that it will make Indian markets less attractive and India will lose out on more advanced products and technology, right? So the point being that a lot of initial reaction was from the perspective of the device manufacturers, given that the price cap is on devices. Of course, device manufacturers work in an ecosystem of different stakeholders and different players. So one of them, which I think is represented fairly well in this forum, are the hospitals. So what, again, I mean, there were different reactions, and I'm only highlighting some of them. For instance, Narayana Hrudayalaya said, hey, listen, these price caps on stents means that we will have to adjust our pricing strategy for the whole procedure, because the procedure is a combination of products and services. If products prices are capped and our margins are capped, we will have to rationalize the margin structure for the services. And the argument was that these services were significantly underpriced. So here you can see earlier procedures were underpriced and implants were overpriced. So there's a recognition that the implants by themselves were overpriced, but they were only kind of cross-subsidizing for the services themselves and the procedures that were underpriced. And so we are going to now reallocate the prices so that, I mean, this is unsaid, is that effectively it is unlikely to change anything for the end consumer. And this blog by one of the doctors, you can go to this link later, I can share this, basically makes the same point. That based on this, it really should not make a big change in the expenditure for the end patients. Again, there are a lot of assumptions that go into these claims, and I will try to unravel them one after the other. One important point to make here is that most of this discussion, so even the policy formulation, the responses that you're seeing are all keeping in mind implicitly the patients who pay for these procedures out of pocket. And that's actually an important point I'll come back to in a couple of slides. So based on the data available in the NPPA orders and some cost elements, we did sort of a rough calculation. I don't claim this to be perfect at all. To say, well, the margins in the value chain were highest, so to speak, for hospitals and distributors, and because of that 8% price cap and the price cap on the retail price, they are the ones who would be the most affected by such a price regulation. And so we need to carefully look at how they are likely to respond. So these are some of the possible responses to the price change, and we'll see some others. So that's from the hospital's point of view. And now entering a more sort of tricky area, which is the physicians themselves. Again, here is a news report that talks about things that all of us kind of know anecdotally. That doctors, some doctors, let me put it this way, some doctors benefit a lot by doing these procedures. And these benefits may come from, what the press is calling freebies and kickbacks. Their computers or phones. Thank you so much. Right. And so, from an economist perspective, if these economic agents, and doctors and hospitals are economic agents, if it's going to affect their incentive structure, they may look for ways and methods by which they can recover their normal, right? So there may be other ways to compensate for this reduced income stream. And one of the possibilities, again, I'm not a doctor, I'm just sort of, stumbling through all this, and I'm happy to hear comments. But when I have had interviews with doctors and cardiologists, there is a recognition that there are alternatives to PTCA, alternatives to stent implants, which are, one of them is of course the CABG procedure, and this is based on the American College of Cardiology appropriateness criteria. They are saying what is the appropriateness score based on different conditions of the patients, and look at the numbers here, they're going from 60 to 70, etc. Right? So I'm just showing you part of the table. Suffice it to say that whether this procedure is appropriate or the other procedure is appropriate is not trivial and straightforward, and it leaves a lot of room for judgment, expert judgment. And when a particular patient may be appropriate for both procedures, or both procedures may be appropriate for a patient, as a secondary set of criteria, these financials and economic considerations may come in. Again, I'm being very, very guarded in the way I frame this, as you would notice, because I, again, do not have any direct primary evidence to claim. I don't want to go so far as to say that doctors are exploiting patients to make money from this, etc. But there is a room for ambiguity from a clinical perspective. Both procedures may be appropriate. And then if one procedure has benefits, financial benefits over the others, it is not irrational for these economic agents to go one way versus the other. Okay, so that's the physician's perspective. We talked about the hospitals, then the physicians. The third stakeholder that one needs to think about are the insurance companies. So if you remember, I said earlier that the pricing policy was designed keeping in mind the burden faced by patients who pay out of pocket. And in general, in India, a lot of health expenditure is out of pocket, substantially larger than many other countries. However, based on this particular issue brief that was released by the Observer Research Foundation, things are slightly different for coronary procedures. And the data is coming from 2014. There is a sizable contribution of organized financing methods, private health insurance, as well as government insurance schemes. And these are likely to increase as the penetration for PMJ increases further, which is an important point that we will come back to when you look at the results. So now think about this: when a patient is treated for these treated with these procedures under the insurance schemes, the incentive structure is very different for hospitals, because as soon as the price control policy comes into effect, it is not going to automatically alter the contractual arrangements between the insurance companies and the hospitals. So hospitals will continue to get paid for some time, whatever they were getting paid before the policy changed, but their input cost structure as it pertains to the device itself is going to change because of the price cap introduced by the policy. So this is where we talk about unintended consequences, and we'll unfold this as we go forward. Policy that is meant to reduce the burden on people who pay out of pocket may have different impact on the incentive structure of one or two stakeholders in the value chain, because of the way other financial arrangements are in place between these players, specifically the insurance company and the hospitals here. So with all this background, this is what started to inform our thinking and the research design. And we said, hey, one approach to get to the bottom of this is to actually just interview doctors and hospitals or survey doctors and hospitals. And we began on that journey. But as you can imagine, if I asked respondents to go on record on an issue like this, it's going to be difficult. The responses are unlikely to be unbiased and objective. And so then we wanted to look for alternate ways to test some of these hypotheses. Could I again request participants to turn their microphone, please, to avoid echo and disturbance? Please, if you can mute yourself. Okay. So this is then where we started to look for publicly available data sets, which we can analyze to come to some conclusions about the effect of this policy. We found one such publicly available data set, which was on the insurance program managed by the Suvarna Arogya Suraksha Trust in Karnataka. I mean, this insurance program has been known by various names under various government regimes, so I'm not going to go into the proper nouns of the insurance program. And the data that we had was on 76 hospitals, both public as well as private in those 76 hospitals. And this was monthly data available from February 2016 to February 2018. So roughly, a year worth of pre-policy data and a year worth of post-policy data. Again, I'm requesting participants to please mute their microphone if you don't mind, to avoid echo and disturbance to other participants. Thank you. So our goal was to first try and understand what are the margin structures or incentive structures for hospitals for these procedures. I'm sorry, I think I have to ask people to mute themselves. There are a couple of participants who are not on mute. Please.
Very good. Okay.
He is having conversation.
Mute ko unmute karo.
Dr. Murthy and couple of others, if you can please your microphones, I would really appreciate that.
आपका कैमरा ऑन करना.
Okay. Let me go back to the discussion. So first task for us was to try and understand the margin structure for hospitals for these procedures under the Suvarna Arogya Suraksha Trust pricing. And believe me, this was not a trivial task because some of these cost structures are not readily available. The pricing may be. So the way we went about this, I've just sort of put down a stepwise procedure that we followed. I do not claim this to be perfect. And if people have ideas on how to improve this and make it more watertight, I'll be all ears. We started with a report that was created by the Karnataka Knowledge Commission, and this was called the Karnataka Public Health Policy Report. We were fortunate to find this source because then we could sort of use this report in conjunction with the data set, both coming from the same state. In that report, we had data on the cost for PTCA procedures involving one stent BMS procedures. And so the cost data we started with, and then subtracted from that the cost of the BMS stent itself pre-policy to arrive at an estimate of what may be the cost of all other services that are part of this procedure. We assumed that this cost of the procedure is the same for one stent DES PTCA procedure. Again, it is unlikely to be the case. There may be slight differences in the services that are provided for DES versus BMS, but in the absence of any better information, we made this assumption and made it very explicit. We then took the reimbursement data, reimbursement rates for DES PTCA procedure under the insurance program, and then took the cost of one DES stent post policy, which is the price cap that you saw earlier, to arrive at the loss that the hospitals will incur if they conducted a one stent DES procedure after policy change for this insurance program. And then you can do the same calculation for procedures that involve two stents, drug-eluting stents. The only change is that instead of 30,000, now there are two stents, so the cost of the stents is 60,000. Again, the cost of all other services may be slightly different, but again, we did not have a very good basis to scale up or modify these costs, so we continue to keep them and make the assumption more explicit. So these are the losses that are likely to be incurred after the policy change. Compare this with the loss incurred for CABG procedure, which would not change because of the policy, because there are no changes to... I'm told by the IT support team here that you're not able to listen to me. Can someone maybe just say yes if they are able to listen?
Yes, I think I can listen. Yeah.
Thank you so much.
We can listen.
Yes, the problem with some participants. I apologize
Loud and clear.
for the disturbance. I'll continue with the presentation. Okay. So my point was that these are the sort of loss estimates for hospitals for each of these procedures under the reimbursement rates in the government insurance scheme in Karnataka. And that could be compared with this amount, which is the sort of the loss incurred for CABG procedure, again coming directly from the report that I cited earlier. The main point to make here is that the profitability or lack thereof of CABG procedure is unaffected by the policy change, but the loss made on these procedures will be affected by the policy change. Which way one can discuss in greater detail, but at least one input price has significantly lowered for the hospitals. So it is likely that this procedure could become slightly more attractive to hospitals compared to CABG, again, within the study context, which is this insurance program whose prices are fixed just before and after the change in this policy, right? So keep all that in mind. This is now showing the changes in procedures before and after the policy was put in place. So what you see on the left hand side are number of procedures done total from February 16 to February 18, and then monthly average per hospital. So this is per hospital per month in the data set before the policy change and then after the policy change. And just to make things very clear, we have removed February 2017 from this calculation because that's when the policy sort of came into effect. Looking at a clean before policy and after policy. And then these are the differences and these are the percentage changes, again, per hospital month basis. So I'm highlighting two main things here, and I will make the results more concrete as I move along. Just on the basis of these numbers, which are not our final results, we call them descriptive statistics, there seems to be a reduction of 20% in the number of CABG procedures done, and some reduction and some increase in different kinds of PTCA procedures. But the biggest change seems to be in the DES emergency procedures. We had some data on elective versus emergency, a 61% increase in DES emergency procedures. Combined all PTCA procedures, there is a 3% increase in PTCA procedures. Again, these are what I would call as descriptive statistics, and they are a result of many different things that are going on in addition to the policy change that occurred in February. There are a lot of apples and oranges mixed here, different hospitals, public hospitals, private hospitals, patients may be different, etc., etc. And so this is not the final set of results, but an indication that something may be happening. And so the next step then is to try and get to the bottom of the effect of this policy change after controlling for all these factors. And so what I'm going to show next is a set of results from statistical models that we fitted to the data, which control for these confounders. And I'm going to go step by step to show what these results mean. I do not want you to really read through this entire large table. I will only say that there are 5 different models that are fitted here. The first model only looks at the change in PTCA procedures compared to CABG procedures at a very high level. The second model looks at changes in both DES and BMS procedures compared to CABG separately because the financial incentives may be different for these two implants. The third model then looks at electives and emergency separately because the decision making for elective procedures and emergency procedures may be different. As a result, the role played by economic incentives could be different in these two procedures. The fourth model then looks at a combination of both, which is BMS and DES separated for electives and emergency to see where actually is the change in the procedure volume. And the fifth model takes into account even the heterogeneity depending on whether one stent was used or more than one stent was used. Okay, so we don't want to just fit one model. We are allowing multiple different specifications of the model. And in all of these models, we also controlled for the and that each year and month, so that so the model statistically controls these as average in the procedures. Then themselves. Person who just joined, could they mute themselves? Ideal would be if the host, which I am not, mute everyone on arrival. I'm sorry, I'm right. Okay, I'll continue. So these are the 5 models, and I'm going to now go one by one and highlight what these results mean. So for the first model, there is a positive coefficient for this PTCA variable, which means that PTCA procedures increased more than the reference procedure, which is CABG, when I compare the pre-policy and post-policy periods. So this is starting to show that after controlling for all confounders, there seems to be a shift from CABG to PTCA procedures. When I look at the next model, I see that this increase is observed for both DMS and DES, but the increase is slightly higher for DES. Again, keep in mind that DES implant or that product has a slightly higher price, and so the incentives may be different for DMS and DES, but both show an increase in volume. When it comes to then looking at elective versus emergency, the increase predominantly seems to be driven by emergency procedures and no statistically significant change in elective procedures. Again, I'm happy to talk and conjecture in detail later, but there is a possibility of the way decision making is done, the influence of the doctor in the decision making could be different when it comes to emergency versus elective procedures, and not to discount the fact that just this fact whether some procedure is an emergency or an elective procedure can be influenced by the physician's advice at the time of conducting an angiogram. Depending on what the physician judges the case to be, it can become an emergency or an elective procedure thereafter. Again, not in all cases, but in those marginal cases. And then the last model basically shows that this pattern continues to hold even if I separately try to account for the fact that some procedures are involving one stent, some are involving more than one stent. Now, I have only circled one column in each of these models and left the other column empty because that column is for public hospitals and there is almost no coefficient that is statistically significant in these models. Which basically goes to show that the increase that we see overall is driven only by private sector, private hospitals data and not public hospitals data. So other way to interpret this is that the increases are happening in the procedures done by private hospitals and not the public hospitals. So to summarize then, after controlling for all confounders, after controlling for hospital specific factors and seasonality, month, year specific factors, we see that there is a greater increase in PTCA procedures, especially emergency procedures, compared to the reference, which is the CABG procedure that did not experience this policy change in the prices. Okay, now, is it possible that it could be happening because the patient mix is very different before and after the policy change? So based on the crude data that we had available publicly on patients, which is essentially age and gender, we do not see that to be the main factor for driving these results. The age and the gender mix is very, very similar between the pre and post policy periods. So what can we take away from these results? What can we qualitatively say? So here are a few things. The policy itself was a one-size-fits-all structure, which means the price caps were introduced for all patients, irrespective of what are the financing mechanisms for these procedures. As I said earlier, the target audience or the target beneficiary group was those who pay out of pocket. But at the same time, these same cost structures and price structures apply to patients that get their care under other financing mechanisms, such as the government or the private insurance programs. That's one point. And so that may create differential incentives, differential motivations. Second, for the underlying condition for which price control is implemented, there is a gray area clinically, and that creates alternatives. And so there may be a genuinely, again, a sort of genuine set of marginal cases where more than one procedure is appropriate, which means that the price control is only partial and different economic agents have latitude to exercise their judgment, and that can drive some of the results. And combine that with the fact that the incentives are different for different players in the value chain, hospitals, physicians, etc., which then, along with this existence of alternatives, creates incentives and possibilities of substitution. Now, like any other study, this is not devoid of limitations. We were working off on a very limited data set from one state in this large country and one specific insurance program in that state. And even within that, the data was only that was publicly available. We did not have access to detailed patient level data. Beyond this, ideally we would have wanted to have patient level data on those who pay out of pocket, which is really the main intended consequence of the policy change. And we also could not directly validate or verify different costs that were reported in the previous studies. All of this requires extensive primary research. But it is also not just a function of the amount of effort that we are willing to put in. It requires participation by different industry players. And given everything that I have said already, it is understandable that there are concerns and people are guarded about sharing the data, even anonymously. Believe me, I have reached out to several private hospitals, insurance companies, also the insurance regulator, to say if any de-identified, anonymized data set can be made available to strengthen the study, but this is the best that we have so far. Okay, so please keep these keep these limitations in mind when you interpret the results. Now, so what do we do with these results, and what do we do now going forward? Right. So I think there are a bunch of implications that come out of these results. If these results were validated in other studies through maybe stronger studies, etc., what remains to be discussed and analyzed is that there are various value destroying steps in the supply chain that exist today. And I'm having this discussion with different private hospitals, device manufacturers, and also NHA about how the supply chain for devices works. What are the inefficient or value destroying or wasteful steps in the process? There is a lot of lack of information about future demand for these devices. There is a lot of variety in the devices that are used. Not all the variety may be necessarily warranted. And so there could be room to rationalize some of the variety, use that to drive better demand forecast, and then help input that demand forecast into planning of production and distribution of these devices to bring down the overall cost structure. Again, this is not only theoretical reasoning. This reasoning has been used in many other commodities in many other parts of the world. especially where the problem is much graver and the pressure on cost reduction is much higher, such as global health commodities. So it can be done. It can also be done to change what was traditionally a relatively low volume, high cost business into a high volume, low cost business. And probably there is an opportunity here to do something different in light of where PMJ and Ayushman Bharat program is going. Again, I'm not claiming that any of this is straightforward and can be done with the flip of a switch. But there are possibilities. Again, as I said, I'm talking to NHA about making pertinent data available so that one can make more evidence-based decisions and designs on these aspects. And I'm happy to talk more later. I am personally, closely involved and analyzed a similar, or let's say somewhat similar but somewhat different initiative in the TB space on diagnostics, where a new molecular test called Gene Expert was introduced in the private sector. The prices were prohibitive for its expansion in the private sector. An industry-led consortium of private labs was created, and the price structure and the margin structure in the value chain was rationalized by working with the industry and with the National TB program to derive appropriate ceiling prices. And this was a quote-unquote sort of informal relational agreement made by the private players that they will abide by these ceiling prices, because they felt that it would be incentive compatible, as it would lead to an increase in the volume of these tests done. So this is the nature of the win-win situation, where higher quality tests become more accessible to the population. And at the same time, they mean good business for private players because the margin structures have been rationally modified to create a win-win situation for all the players. If you were interested in the details of this initiative, a manuscript on that experience is published in BMJ Global Health, which has some data on how the margin structures were modified, and then also what was the impact of that on the volume of testing in India for those tests. I will stop here. I will recap and remind you of the preliminaries that I had set out in the beginning. I do not have any conflict of interest. This work was not funded by any industry body or industry player. Please note the specific study context in which the data analysis was done. The results are not a statement, indictment, judgment, praise for any specific players, hospitals, or doctors. And then our goal is to drive insights into what makes policies effective or ineffective. Based on this study alone, I would be very reluctant to pass the judgment on whether this particular policy was a success or a failure. If anything, this is an invitation to for people to join and probably commence on more studies that can either complement or even negate the results from these studies. This is how science progresses. So I'm happy to be part of that conversation. I will stop here and I will open the forum for questions. The best way to ask the question may be to type the question into the chat window, and I will take these questions one by one so that we have some sort of order and decorum. My contact details are here in the meanwhile. If people wanted to drop off and contact me later, I'll be happy. But please feel free to ask any questions. Please type them in the chat window, and then I'll read them out for all the participants. Okay, I've got one question already, so I'll start answering that. So one question by Sundar Rajan Srinivasan is, if there was no reduction in incentives for hospitals for CABG, common sense would predict an increase in CABG, not the reduction. So partly correct, there are no changes for CABG incentives, but note that within the insurance program, the way, the direction in which the incentives change were to reduce the input price for PTCA and keeping the reimbursement rate the same. So reimbursement rate minus the input prices is one measure of the margins that the hospitals get. And that margin is likely to be higher after the policy change for PTCA as compared to before. And as you say, no change in CABG. For CABG, there is a flat line before and after the policy change when it comes to margins. But for PTCA, there is an increasing trend in the margin before and after the policy change. Again, this is not a positive margin, it's a negative margin, if you will. So hospitals were losing money before the policy change, are losing money after the policy change for this government insurance scheme, but they are losing less and they're losing much more on CABG. So now they will move on the margin patients from CABG to PTCA. So that is my explanation of what's going on. Okay. We see any other questions? Okay, so Abhinav Khare asks, have we seen insurance prices come down eventually? That's a very good question. I have actually not pursued that thread. But I'm happy if other people have any thoughts and they can send those to us, and we can, make them more public or disseminate those pieces of information. When we commenced on this study and we're talking to private insurance companies, they were in the process of renegotiating prices with the hospitals, both private and public. But unfortunately, I have not kept track of where that eventually went. One would rationally expect them to change. Okay, Ashish Kapoor is asking, have you seen a particular correlation in billing patterns pre and post policy? The ballooning procedure, which was included in the package for PTC, is now being charged separately for each. These are absolutely good and appropriate questions, Ashish. Thanks for raising it. As I said, we were working off of such a limited data set. Because of the trepidations and concerns that different players may have on sharing more detailed data. And if anything, I want to use this forum for is to seek inputs on richer data sets from people who are representing different industry bodies to expand this knowledge envelope. There is a way to use this data anonymously in a de-identified form. This is what researchers world over do. So if there is interest in this forum, and I'm sure Siddharth will take this up later, we would love to do an expanded version of this study using much more granular data so that more effects, both intended and unintended effects of the policy can be uncovered. So please keep this in mind and think through what could be done going forward. Mahad is asking, do you see ultimately procedure price cap itself coming instead of price? Yeah, so this is, it's again a natural way to proceed in terms of thoughts. Can I make my partial price control more and more complete and less partial? Sure, it can be done, but again, rational economic agents will always figure out ways to get around that. So the main question I want to leave you with, or thought I want to leave you with, is can we create pricing mechanisms that are incentive compatible? Right? So there is a large literature in economics about mechanism design, which is how do I design incentive mechanisms that improve social welfare, but are also incentive compatible for economic agents. And the basic premise there is there may be underlying inefficiencies in the way things are currently organized. If I can remove those inefficiencies, I can expand the pie and then reallocate the pie so that all players benefit. Otherwise, this is a never-ending story of put more and more and more restrictions, more and more price caps. What happens to the ability to monitor all those very, very nuanced caps on different components of the procedure? That would become more and more ineffective. Okay, I'm getting a lot of questions. Please allow me to read. and then sort of say them out loud and give my response. Manoj is asking, do we have any sources to get data India-wide? I believe this study is only absolutely, as I said earlier, if you have data sources, if you're willing to contribute to a repository of data, I can sort of open up a link on GitHub or wherever it is, and Siddharth can coordinate. It would be fantastic to get a representative nationwide data set in an anonymized, de-identified fashion. So all the questions related to data and the scope of the study, I'm going to put aside for now because I don't have more to say than what I've already said. Shabnam is asking, hospitals who were earlier not being able to access patients for interventions under PMJ would have pushed the total volumes up, and hence the no change. Sample size has to be much larger, Sarang. And I agree, PMJ was not a big deal in the window of the study that we did. A separate study needs to be done to look at the impact of PMJ on access to care, which is the main story. But that would require completely, again, different data from people who were previously not covered under any scheme, but now are covered under PMJ. Again, I agree that it should be done. I also agree that we don't have the wherewithal to do it as it stands now. Okay. Namita is asking, have we seen that the total cost of PTCA to a patient still remains escalated despite the price capping? We have added a lot of variable factors that keep PTCA attractive to private hospitals. Fair enough. When I was creating the background story for this, before I went into my own research, I did talk about these issues. Again, remember that within the study context, which is a public insurance program, I would conjecture that the cost to patients really did not change before and after the policy change because they were quote unquote covered under the government insurance scheme. But the practices that may happen for out-of-pocket patients, where you are reallocating cost and repricing the components of the overall patient experience, absolutely may be happening. Absolutely, I don't have any way to objectively quantify it because of lack of data. Can we get the detailed paper? Mohit is asking, based on the data you have highlighted, I do not see many variables which have to be accounted for. There are many variables that one can account for. The patient mix can be controlled for in much more nuanced manner. There are accepted scales of patient severity, hospitalization indices, etc., etc. We didn't have data on any of those. I will definitely try to make the paper available. It is behind a paywall because of the journal, but I will work with Nat Health and Siddharth to figure out what is the formal official way to share the paper. Please go through it in detail, and if there are any questions, you could reach back to us and we'll clarify things. Okay, Raghunandan is asking, how about looking into the data of medical colleges instead of corporate hospitals? Because there you see they have prices capped much less than the government schemes in Karnataka, because that help understand how volume play is profitable and still manage similar better outcomes. And then he goes on to say institutions like Jaydeva in Karnataka are still profitable. Absolutely. Again, this is an invitation to say, if you know a way by which such data can be obtained, I am happy to put some effort from ISB's side and help to analyze this data. But really at this point, the bottleneck is data of many different types, colors and shapes. If the data is available, there are many good questions that can be answered and possibly useful questions from a policy perspective. Okay. Let me see if I have covered everything. It seems I have covered most of the questions that I am reading here. There is one more. Hamunglung is asking, there is an emergence of indigenously manufactured stents in the market post-policy. What do we see the impact of the same? It's again an interesting question. To be perfectly honest, I really don't know. There are so many unknowns about this. Is the cost structure of indigenous stents different from those of imported stents? I don't want to hazard a guess. There are off the hips comments that I can make, but I don't want to. Is the quality the same? What are physicians and hospitals' decision-making processes? Yeah, I mean, they are cheaper, but again, I think it's good to have data to say how much cheaper they are. What are the sales processes that domestic companies follow versus international companies? How does that influence decision making by hospitals, etc., etc.? So again, a whole bunch of open issues. We are running out of time. We've just run out of time. So what I will ask for Siddharth to do is maybe find a way to channel some of these questions and discussions into a different forum, maybe create an agenda going forward, because this is the thing with research, the agenda never ends, it only adds more questions. But then also, more importantly, figure out a way by which some of you can support answering these questions by cajoling, convincing your institutions to contribute to the data set. And I'm happy to coordinate that effort so that everything is anonymized and de-identified. Okay, in the interest of time, I will stop here. I do have my contact details there, so feel free to visit my homepage if you want to know other stuff that I do, and if you have thoughts on those researches as well, and my email address is there. Now, I said in the beginning that it is very generous of you to devote time to this topic when the main healthcare topic in India is coronavirus and COVID-19. With regards to that, we at ISB and the Max Institute of Healthcare are conducting an additional study to assess the hospital capacity in the private sector that may be available to address the possible upcoming surge of hospitalizations. I am going to copy paste a link to a simple Google Forms survey. Please, if you can, please respond to this survey. Again, all the data would be de-identified and anonymized. We are not going to use this for any commercial purposes, but probably to collate into a report what the geographic distribution of hospital capacity may be to target and tackle the COVID related hospitalizations. So I am in the chat window copy pasting my message and the link to the Google form. I strongly request you to urge you to fill in this Google Forms. Once we get all the responses and collate them, the results will be shared with everyone who participated, but also be disseminated more broadly. And Siddharth may also coordinate if you need more help in filling up these forms. We can share the link on other forums beyond this chat window. Thanks again. Thanks a lot for your participation. Really appreciate your patience. Hope to stay in touch with many of you.
So if I may just take maybe just 30, 45 seconds very quickly on behalf of Nat Health and all of us who were fortunate to be a part of this session would like to really take the opportunity to thank Dr. Sarang Deo, the entire ISB team, for coming forward with this research. In terms of next steps, if I could work with your team, Dr. Sarang Deo, to either circulate this presentation or if there is a recording of this WebEx that was done, I'll be happy to circulate it to the larger groups who could not participate. And some of them wanted to come back later after going through the materials. I'll be happy on behalf of Secretariat to collate a lot of the suggestions, ideas that may come in from all of us to take this research forward and maybe work with your team to see how we can create a meaningful construct. Also, from the Secretariat team, Anesha will circulate a feedback form. So for all of you, I think the idea there is we would like to keep these sort of high quality discussions going, hopefully on a monthly basis. And if you can suggest relevant topics and suggestions, which we can add, it will be very, very insightful, and we'll go ahead and plan that. I think, Sarang, in terms of your last question, considerable HFW and Niti Aayog and Nat Health, along with many of the other federations, have played a role. A lot of data compilation has happened. So I'll be happy to talk to you offline and make sure I bring you up to speed and support in any way ISB is trying to add on to the efforts.
Absolutely.
So those are some of my thoughts. I really appreciate all of you for joining and wish you all the best. Thank you so much.
Thank you so much, Siddharth, for creating this forum for this discussion. Thanks a lot.
Thank you, everyone. Bye-bye.